Hello and welcome to our inaugural Lovegrove on Health podcast. My name is Dominic Louks. I'm the product marketing manager here at Skills for Health, and joining with me is the star of the show, Mr. Andrew Lovegrove, who's the senior consultant at Skills for Health. How are you, Andrew?
I'm great, thanks, and really excited to be with you here today. Those who know me will know that I've always got something to say, so being given an opportunity to do this is just fabulous.
Yeah, here we are. It felt like we only really talked about this a couple of months ago, so we've moved quite quickly. For me, one of the most difficult hurdles to overcome was actually the name of this podcast. But there we go, we got that one done quite quickly. But just to give our listeners a sort of executive summary about what these podcasts are about, I'll be asking you about some sort of workforce development issues that are impacting the health sector, and we'll try and focus it on a particular theme.
Yeah, and I think my role as a senior workforce consultant involves working with a huge variety of health sector organisations, really helping them to address their workforce challenges, be it through the development of technical workforce solutions, such as frameworks, designing new roles and ways of working, through to helping people plan their future workforce requirements at various levels. The breadth of work myself and colleagues undertake does give us a rather unique insight into the health sector and the workforce within that sector. In the past, we've tried to share some of these thoughts via our thought leadership pieces, which we've done in a written format. However, that involves someone sitting down at a screen, not least writing them, but then other people have then got to read them either on a screen, print them off. That takes time, and more often than not, other events, more important, more urgent, take over, and people don't have an opportunity to engage with us. During the last few years, podcasts as a format have just exploded, and I've personally come to benefit from them during lockdown. Those days of lockdown, no contact, I'd find myself going for a walk during the day as part of my exercise. And to make it more interesting, I discovered a whole new world of interesting chatter and insight. And I now regularly listen to podcasts on a whole variety of topics. So the idea was we try and do a podcast on the issues that I and others that I work with and see on a regular basis to try and provide some insight into the issues, the challenges the health sector's facing from a workforce perspective. And then people can listen to them in their own space at their own time. And we also thought it's a more authentic way to share and disseminate important messages and opinions on issues that are impacting the healthcare workforce.
Absolutely, totally agree. Hopefully this is just a more engaging delivery, and at the same time, hopefully me and you will have a bit of fun as well. So our conversation will always attempt to sort of dial in on a particular theme. I know for this first episode, I'm going to be trying to get your thoughts on the COVID recovery, obviously with your workforce slant. But our podcast will always start with a brief news recap about what's caught your eye in the health sector over the past week or so. So I know there's quite a lot to choose from, Andrew, but any standout highlights that particularly jump out?
Well, this week I was reminded of the fact we are experiencing record ambulance delays that are leaving patients waiting hours for emergency care to arrive, and overall waiting times increasing every month. With patients waiting hours at home, more patients waiting outside hospitals for a bed to become available, and alas, for a small number of people, but very sad nonetheless, ambulances are arriving too late and patients actually dying while waiting for help to arrive. And this is impacting, obviously, the patients and the relatives of those involved, but actually the ambulance staff and staff overall within the sector.
Any pointers for this trend? Is this a sort of workforce supply issue or absenteeism or multitude of factors?
I think for people who already watch a variety of programmes that cover ambulance services and A&E departments on the television, for example, will see that even before the pandemic, our ambulance service, our A&E departments were pretty much at capacity, on a good day. So in the past few weeks, months, well, coming up 2 years now, they've had to deal with this additional demand on their services. So there's been a service demand explosion, but particularly in the latest wave of COVID, we've kind of had that double whammy of record levels of sickness from the workplace, which is just, ambulances don't drive themselves, machines don't look after people independently. So people have not been able to attend work. So that's affected ambulance organisations to be able to have the right numbers of people in place. But then I'm reminded of countless examples of ambulance crew who are just stacked up outside A&E departments waiting to offload their patients. The target for that should be around 15, 30 minutes, where I heard one paramedic talk the other day, out of a 12-hour shift, he spent 6.5 hours in the back of an ambulance waiting to offload his patient into an A&E department that was already bursting at the seams. And of course, that ambulance was just stuck there and couldn't respond to the next call. And the call handlers had the calls just stacking up. And we're actually saying to a number of patients, if you can make your own way, that will be quicker than waiting for an ambulance. So I think it's a multifaceted. I don't think there is one reason for the stories that we've heard about this week, but I think lack of staff, the right numbers of staff, clearly has got to be a factor, but also just the sheer level of demand across the system. Ambulances, like all elements of the health service, do not operate in isolation. We all have dependencies, handoffs on each other. And when one end of the system is under strain, the whole system's under strain.
Yeah. Anything else?
Well, this week, our Secretary of State was before the Health Select Committee talking about the abolishment of the 4-hour A&E waiting target. It feels a very emergency care week this week, actually suggesting it leads to some perverse outcomes for patients. And his argument being, if a patient is in danger of breaching, for example, all of a sudden when that patient gets to having spent 3 hours, 55 minutes in A&E, guess what? They'll admit the patient just to not breach the target. And he was suggesting that was a poor outcome. And, I think I've been in the health sector a number of years now, and I've seen the whole cycle of this target from its creation through to the present day. And it's always had a mixed response from people. Targets generally, some people see the virtues and the positives of them. They help focus people's minds. They focus priorities. They help identify success and are able to be measured against, where actually sometimes, to use that old expression with targets, we hit the target, but we missed the point. And there is people who would say that the 4-hour A&E waiting time target has become a victim of its own success, where people are struggling to engage with other areas within the health sector, can't get an appointment with a GP, can't access primary community care services elsewhere. People have said, well, I'll go to A&E, I'll sit in A&E, and I know that in 4 hours I will be seen. So it's been round for 15, 16-ish years now as a target. Is it time to review it? Perhaps, but one can't help but wonder, if A&E wasn't under so much pressure at the moment, would there be the incentive for government to remove the target? I'm not quite sure what the motivation is by the removal of the target right now.
Okay. So obviously the wheels in Westminster turn quite slowly, but in your opinion, do you think there is actually a strong likelihood that this abolishment might take place? And if so, when?
The wheels turn slowly when they want to, and they turn quickly when they want them to. So I think, given the political landscape generally at the moment, they will pick their moment of choosing when it's advantageous to do it. I'm aware within health there is the delay in the launch of the ICSs. There's still legislation that needs to pass through Parliament with regards to some of the structural changes. So my sense is they will not want to remove one of the key metrics of success for the NHS until we're the other side of some of those changes, those structural changes. However, now that I've said that, the complete opposite will probably happen. It's hard to predict which way this will go, but I think there's enough on their plate at the moment from a policy perspective without tinkering with one of these key metrics. I wonder whether or not the Secretary of State was signalling an intention to the Health Select Committee rather than saying this is going to happen in the next 72 hours.
And I know there was one other news item that caught your eye about the discharging statistics.
Absolutely. The number of patients in hospital who are medically fit to leave but are still within beds has increased this month. And that's despite NHS England setting targets for trusts to dramatically reduce those numbers. I think it was last month NHS England told local systems dramatically reduce the numbers of medically fit patients who remained in hospital to free up those beds. Going back to our earlier news item, if we get people out of the beds, that means we can take people from A&E and admit them. We can free up the A&E to let ambulances offload. But that hasn't happened. There's been a 2% increase during the last month. And I think this just goes to show a complex problem requires complex solutions. But it's been made even more challenging with record numbers of staff sickness, both within the health and the care sectors. So it doesn't really come as a surprise to me, but I'm fully aware of the impact that it does have on people who are trying to provide care at the moment. I mean, this month, January, February, two of the worst months of the year for the health service. So when you've got record levels of sickness from the workforce, it could not come at a worse time.
No, feels like we could do a podcast just talking about news.
Well, that's 13 minutes without even trying.
I know. Okay, so what we're going to try and do now is just concentrate on the theme for today's podcast, which was talking about COVID recovery. So first question, wearing your workforce development specialist hat, what concerns you most about the UK's ongoing recovery from COVID?
Well, I think for me there, that use of the word ongoing, COVID, it's really been the gift that's just kept on giving. I don't think we can think of COVID and our recovery from COVID as a one-way linear approach. I remember in the summer of 2020, there was a sense of, oh, the worst of it's over, back to normal. I remember being in the car, driving back from a day out in the Peak District, and there was the whole thing about let's get everyone back into the office, almost it's all over, nothing to see here. And then we had the second wave.
There's the Eat Out scheme.
Eat Out to help out. It's, like I say, all over, nothing to see here. We're on our path to recovery, where actually it's felt much more cyclical in nature. And that's a challenge, I think, to us. And we do need to reflect on what we've learned from what's gone before, really identifying the things we've done well and maximising that, but equally look at what hasn't worked so well and trying to avoid doing those things again in the future. I think it's exposed some of our fragility across our health and care systems. We've said, we weren't exactly slack before the pandemic. Our ageing population, more and more demand on our services with ever increasing complexity, coupled with changes and advances in healthcare solutions, the elastic band only gets pulled in one direction. So what concerns me is that the normal quote unquote or non-COVID demand hasn't gone anywhere. In fact, it's just been waiting for us in the wings, just building up, building up, building up. And COVID has just added onto that.
I was just going to ask, do you think actually as a country, as an NHS, we were prepared for a pandemic?
I think the answer to that question overall has got to be no. I don't think we were prepared. Part of being prepared for a crisis, whether it be a pandemic or anything else, has got to be you have the capacity within the system to respond to unforetold or unforeseen consequences. Little insight into me, was a huge fan as a child of the Carry On films. And there's a very infamous scene in one of them where Frankie Howard says to a fellow patient, I'll say one thing for him, it's a nice warm bed. And I think it was Sid James who replies and says, should be, only took him out half an hour ago. And of course, everybody laughs, isn't that silly? Isn't that funny? Well, that's become the practical reality. The bed is metaphorically, for all my infection prevention control colleagues out there, yes, of course, the bed has properly been cleaned and the area made safe for the next patient. But metaphorically speaking, our beds are constantly hot.
Just trying to think what that Carry On film was.
I think it was Carry On Doctor from... that's the one where Barbara Windsor causes Sid James's blood pressure to blow the mercury from the top of the machine. That's probably far too much of an insight into my age, and B, the type of things that I find funny. So probably least said about that. But it does feel that learning to live with COVID feels more like living with a new long-term condition we've just identified, as opposed to something that will just go away. And it's the non-obvious things that we haven't done which have concerned me. In a past life, I was a health visitor, and I know that services had to radically operate in a different way, minimising face-to-face contacts, home visits, telephone consultations. And I just wonder how many child health checks haven't happened or happened in the best possible way. And I'm always reminded of how crucial it was to detect developmental delays as early as possible in order to minimise the impact of that and maximise health outcomes. Children who enter mainstream schooling with those delays are immediately disadvantaged, and are highly likely to fall behind and stay behind. And that has all sorts of implications for later in life, in terms of life chances, but also health outcomes. So that worries me overall in terms of our COVID recovery. And I worry from a workforce perspective that we have a workforce that had got challenges, a bit like the health system in general. Our workforce within the health sector had challenges before COVID, and COVID has just really shone a magnifying glass on some of those challenges. And I think I don't see, if that was the stick, I don't see where the carrot is for healthcare staff, because actually what they're being told is the pressure isn't going to get any less. You've got, a backlog of clinics, of patients who need to be seen with non-COVID. When I first entered the healthcare workforce, it was at the time of the new Labour government in the late 90s. And I remember then we had a huge backlog of elective care, and trusts were given additional money to do extra operating lists. And we used to call those Dobson lists, named after Frank Dobson, who was the health secretary at the time. But people were willing to do that because they could accommodate that. There was some flex in the system to do those additional lists. People were willing to do extra hours, work overtime, what have you. But when you've just been through what we've been through for the last 2 years, that's not going to have the same appeal. So I worry about the longevity in a variety of workforce settings and workforce professions to actually be able to respond to this unmet demand that we've had to put to one side in order to deal with the crisis, which comes back to your earlier point about our capacity and our ability to respond to a crisis.
Do you think the ongoing recovery, do you think we've been too premature lifting restrictions? Especially when you look at the number of deaths that have been occurring in the last few days.
I think it's hard to know. Potentially, yes. I'm reminded of the World Health Organization, who said, don't think this is over. Whilst it seems that Omicron hasn't been as devastating as we thought it was going to be, and the messaging we had back in December, you're right, there are still not insignificant numbers of people dying, people in hospital. So again, anyone who wants to hit the all clear klaxon, I think, is doing that prematurely. And it's still a global phenomenon. We may, if we were looking at just the UK, there is potential that the pandemic is moving to the beginning of what we might describe as being more endemic in nature. But I don't think we can say that across the world. And I'm reminded of, I know we'll probably talk about vaccines later, but I'm reminded of something that was said last year, nobody's vaccinated until everybody's vaccinated. And we've got a long way to go on that, as we know. So I think there are some hopeful signs, but I think we've got to be cautious about how we move into that awful phrase, that new normal. But I know there are other considerations outside of health that people have to consider. So it is complex and it is complicated.
So just continuing this theme, next question. We're talking about the four nations and the fact that they've undertaken slightly different strategies and approaches to COVID and lockdowns to minimise the spread and protect the NHS. With the benefit of hindsight, do you feel any particular administration has got more of the big decisions right?
Well, as you say, with hindsight, and hindsight is a brilliant thing, and if only we had a crystal ball today. I think, and we know without getting too political, it's fair to say that the devolved nations have taken a more cautious approach to dealing with COVID. Has it worked? Well, one could argue that those health systems could have been under even more pressure without that approach. However, that approach does come with costs of its own, economic costs, wider societal costs, other health outcome indicators. I think what I'd say is it's not a zero-sum game. There are those who think that England, for the Omicron crisis of December 21, was actually more on the money than the devolved nations. But was that luck, good judgment, a policy decision that's been implemented and it turned out to be the right policy? Probably a mixture of all of that and a bit more alongside. And I think looking from the UK farther afield, I don't think there's been one single country that's got it 100%. I remember back in 2020, the New Zealand approach, which was widely applauded and I would describe as a very pure response, lockdown and keep lockdown. But that proved not to be sustainable. And, the world's borders aren't respected by a virus. And you can't live sustainably in a sealed container in perpetuity. Equally, there were those countries who said, virus, what virus? They've paid a heavy price as well. And those are two ends of the spectrum. I don't think there is a perfect solution. So I think I'm naturally a cautious person, so I can see some of the merits in what some of our devolved nations have done, but I can hear the argument on the other side of the fence saying, well, no, we've got to mainstream this more, because are we saying forever we're going to live in a world of potentially, lockdown could come in with 48 hours notice, and what does that do to people's lives and lifestyles? So it is complicated.
New Zealand are back in lockdown, aren't they?
They are.
But just a handful of cases as well.
I mean, pure lockdown, lockdown, stay lockdown, ultimately will work, but it comes at a price nonetheless. Without wishing to talk about another Antipodean country and tennis players, I'm aware of many families, friends who've not been there for significant life events, been there with loved ones during the last moments of life. That has an impact as well, and the lasting impact of that will still be there, hopefully long after we're talking about the virus.
Obviously, we've touched on some of these points already, but another question I've got for you. So, of course, the health sector's been under intense pressure, working tirelessly since the pandemic began. But have you actually seen any instances where this might positively impact the workforce and future people strategies?
So it's very hard in a crisis to try and find the positives, because you would hope there wasn't a crisis, so therefore you wouldn't be looking to find positives. However, I think there have been some with the pandemic. I think it's shown that we can be fleet of foot when we need to be. We are able to remobilise our efforts. We are able to work differently, and we can respond, our workforces can respond to the challenges, the tasks that are put on them. I know there are those who would subscribe that, the public sector is a clunking machinery of bureaucracy that, takes years to just decide, shall we change the light bulbs we use? But actually the pandemic showed, no, we can work quickly, and we can respond appropriately. I think it enabled us to put process to one side, and that we could focus on the patient, the individual, the service user. And actually the world hasn't tumbled when we've done it. We've thought about what's best for the individual, as opposed to it must be because that's the way we've always done things. I was involved in a project last year and the year before, the end of the year before, where we were looking at how health and social care services and workforces in the community had been working. And they recognised that they needed to work in a much more collaborative fashion, and some of the things that historically they'd been very precious about, only somebody with this job title could possibly ever do this thing. The thought of somebody else doing it was nothing short of heresy. Well, the pandemic, we hadn't got the luxury of that. We can't send 4 different people into one person's home over a 24-hour period. We can only send one person in once to do the 4 things that need doing. So I think it's refocused person-centered care and thinking about what the needs are of the individual, and how can we wrap services around those needs, and how do we deploy our workforce most effectively. Organisational boundaries are not impenetrable, and probably in a future podcast we may talk about the changes to our health systems with the launch of the ICSs. I think for a long time, going way back to the 90s, the formation of NHS trusts, boundaries that's where the boundaries were. And if a patient fell between those boundaries, that was just an unfortunate occurrence, and there wasn't really much motivation to do anything about it, in my belief. But I think COVID showed us that organisational boundaries are not impenetrable, but that requires leadership. And I think our leaders have had to be brave during COVID. And I hope that bravery continues, that they are willing to make tough decisions or decisions that they perhaps wouldn't have ordinarily chosen to make. It wouldn't have been their default setting to make, but their rationale for doing so is in the best interest of the patient.
When the pandemic started, I wasn't working in the health sector, but I totally agree with everything you said. And just as a member of the public, I thought it was amazing how quick we were able to get all the PPE, get a vaccine, just the upscale in terms of the number of people that were entering our health system, and the fact that it didn't break down.
I mean, we're still here.
Yeah.
In spite of some of the bad things that have happened, some of the real challenges that we've faced, our health system is still operating. My A&E department that's up the road is still open. People are being seen, people are being treated. It may not be in the way that we would want it to be, and I think we have to continually strive to make it be what we want it to be. But I think there was a tendency for quite a while to NHS bash. Let's bash the NHS. And I hope one of the positives from the pandemic is that rhetoric's been dialed down. It seems as though that's, for the moment, been deflected over to the BBC, but that's another conversation and subject area entirely. But I think in all of this, it's shown to me that the workforce within our health and care systems, their greatest assets are its workforce. And we absolutely need to recognise that, but understand what that means. Without those people, and yes, we always think of the frontline clinicians, who are, of course, fabulous individuals, but let's also recognise there's some great non-frontline people as well who make those things happen. I was watching a programme that's been on the television recently about the trauma unit at my local A&E, which is one of the major trauma centres in the country. And it's shown people arriving on helicopters from, hundreds of miles away. And there was a moment when they had a patient that they were offloading from the helicopter to take into resus. And there was a moment of, where's the cleaner to do a deep clean of the area that the patient needed to move into. And there was another of, we need to get somebody to ultrasound, where's the porter? And so our porters, our cleaners, without them, our frontline staff can't do their job. So we need to recognise that everybody, I always hate, under normal circumstances, I spend a lot of my life going to different healthcare settings. When anybody ever says to me, oh, I'm just the ... I nearly always pick them up on it and say, you are not just the something. Because if you weren't here to meet me on reception, then I wouldn't know where to go. Yeah. And the meeting I'm having with the medical director or the director of nursing or whoever wouldn't happen, because I wouldn't know where to go and they wouldn't know I was here. So our workforce really are our greatest asset. And I think the case for workforce development, the case for good people strategies, workforce plans, we need to have them and we need to invest in them, because without them, we're not going to have a workforce that we need in order to meet the requirements of today, tomorrow and beyond.
Brilliant. Final question. So, with the restrictions now beginning to be lifted, how can we best protect the patient-facing staff, and especially those who are unvaccinated? And I believe I read it somewhere. Is there about 70,000 NHS staff that are still not fully vaccinated? I think it was in the Times on Sunday.
It's a huge discussion piece. We could probably do a podcast on this topic alone.
Yeah.
I've heard people say, yes, it's going to happen. It will happen. I heard somebody the other day saying, well, as we're looking to open up the economy, return things to a more normal footing, is it such an impediment to have this policy directive now? Will it be implemented? ? Well, at the moment, as things stand, yes, it is due to come into force. So until we know otherwise, that's what we have to base our decisions on. I struggle a little bit, if I'm honest, with healthcare staff from the front line refusing. I can't understand it, if I'm really honest. And the reason for that is, I remember before I could start my nurse training, I had to have a course of injections for hepatitis B. And that really wasn't up for debate, unless I could prove that I'd got the antibodies in my bloodstream already. No Hep B status, I couldn't start my training. It was as simple as that. So many of those frontline staff will already have been in a situation where if you want to come and work, you have to have some form of vaccination immunisation. But equally, I do respect those people who may feel that it's not an entirely proved vaccine. I don't hear people worry about its safety. It's more its efficacy, the fact that we have needed 2 boosters. Does it last for as long as we perhaps would hope? Other immunisations you have once in your lifetime or once every, decade or so. So had it had longer in development, would it have been a better vaccine in terms of its longevity? Perhaps, but I still don't see that, for me, would be a compelling reason not to have it. But again, I respect people who take a different view than that. I think the main thing in terms of protecting is thinking about how do we accommodate, if this runs through to the conclusion that people seem to be talking about, if we are losing thousands of frontline staff, how on earth are we going to fill the gaps? Because we are not sitting on that number of staff, additional staff who are vaccinated. So are we going to have to think about how we redeploy some of those staff so we don't lose them entirely? Thinking about using them. I know NHS England are looking to do some more work around virtual wards and more non-contact type interventions. Can we use staff in those circumstances? The answer to that is probably some yes, but quite a lot no. For me, is have we thought this through in the round? Can we do without them? And if we are going to have to do without them, how are we going to accommodate them not being there in the workforce?
Do you think there will be a softening of the approach by government with this?
I want to say yes, but if I'm honest, I've got no evidence base for it other than that's my hunch.
Okay.
I think when you're presented with, because we now know who those people are, I've almost got in my head a game of Jenga, and we know which bricks we start pulling away at. And I think when people see how fragile the tower is, that may be a reason to pull back on some of the dogma that's around the insistence of vaccines. Having said that, they went ahead with it in the care sector, and we're still trying to judge what's happened within the care sector. Although, going back to previous discussion points, we've seen a 2% increase in people being delayed discharges. So again, all these individual points all tie up together quite nicely. I say nicely, it's horrible, but yeah. It's easy to examine and look at the picture.
Brilliant. I think we've hit our time. So thank you, Andrew, and thank you everyone for listening. You can access and subscribe to our podcast from all the usual platforms or via the Skills for Health website and our social channels. And we look forward to returning with another episode of Lovegrove on Health very shortly.
Bye.